Welcome to AETCM, the Emergency Medicine channel. Shall I?
Yeah.
So today we'll be presenting the case of 30-year-old male who presented to ER with complaints of left-sided testicular pain since 2 days. On 10-second assessment, airway was patent, no secretion, no gurgling. On breathing, patient had a respiratory rate of 17 per minute with a saturation of 100% at room air. Circulation, patient had a BP of 150 by 80 mm Hg with a heart rate of 84 per minute. On disability, GCS was 15 out of 15, pupils equal and reactive to light. On exposure, patient had a temperature of 100 degree with a GRBS of 105. Patient had a pain score of 9 out of 10. At this time, injection PCM 1 gram IV stat was given. Adjuncts to the primary survey, we had done a CBC CRP, and on CBC total count was 17,000 with a CRP of 31.5. After giving paracetamol injection, pain score was reassessed and the patient told that the pain has decreased to 6 out of 10. Sample history.
Go to local examination.
Okay. On local examination, inspection, scrotum appears to be erythematous with the testicular swelling, but there was no ulcers or skin erosions. On palpation, warmth was...
Right side. Okay. Okay.
On palpation, warmth was present.
Okay.
Tenderness was there on bilateral sides, but left was more.
Okay. Left was or right was more? Left the patient had more tenderness. The patient was complaining of right-sided.
No,
left-sided pain.
tenderness.
Okay. Okay. Sorry.
Patient had a tenderness more on the left side.
Okay.
On doing Prehensign, pain was decreasing.
How will you do Prehensign?
We give manually elevate the scrotum and then ask whether the pain is
Sitting
decreasing.
or standing position or lying down position?
Lying position itself. And then we ask whether the pain
But
decreases.
when to elicit, when the patient, we were able to do it in standing position and the pain significantly reduced, that is much more better to do. But you can do in the lying down position also. When you lift the testis on the affected side, if the patient is having
pain decreased, then it corresponds to epididymoorchitis.
It is one of the tools by which in the ED you can say whether to differentiate between a torsion and between an epidermoorchitis. You can do the Prehensign. It's one has got reasonably good sensitivity for and specificity for your epidermoorchitis. Then
Cremastic reflex was elicited. It was present.
Okay.
Then no lymph nodes, inguinal lymph nodes were palpable in the patient.
Okay.
Then we had planned to get a USG scrotum and Doppler.
Okay. Now you tell me the history. What are the sample history? What all things you have asked for?
30-year-old male whose known case of sacral agenesis, obstructive uropathy, single left kidney, neurogenic bladder on continuous intermittent catheterization.
Okay.
History of recurrent UTI, hypertension and bronchial asthma, presented to the ER with complaints of fever since 2 days. It was high grade and associated with chills. Then patient started to have complaints of left-sided testicular pain since the 2 days, which aggravated since last 1 day. Patient giving history of increase in the frequency of micturition, no history of abdominal pain or no history of trauma to the scrotum, no history of any hematuria.
Okay. So basically we have got a patient who has got significant urological issues like having a recurrent urinary tract infection and manipulations being done, self-intermittent catheterization he need to do, and he had obstructive uropathy. What was the reason for obstructive uropathy? Whether it was a stone or any reflux or a posterior urethral?
It was overactive bladder he has.
Overactive bladder he has. So what are the medications that he was on?
Medications...
For this, they will be on medications, no? You didn't take. Okay. So that is a history. So here now we have got a little bit of clarity. So whenever the diagnosis is clear, it's epidermoorchitis, but definitely you need to rule out by doing an Doppler also. Torsion and epidermoorchitis, that is two things that we always in the ED that we need to differentiate between. It is a little bit challenging also because the classical fever, maybe epidermoorchitis, this patient had fever, maybe every time you might not be able to get a history of fever. They gradually just come into the EAD with a history of pain over the testis. And what are the reasons for testicular pain? Can you just elaborate me what are the differential diagnoses depending upon the age groups? What are the possibilities that you need to consider when somebody is coming you to the ED with testicular pain?
In ER, first prior importance is to rule out any testicular torsion is present.
Okay. So which age group it will be more common? That is the next question.
In the post-puberty age, it will be more higher.
Okay.
Then
So maybe somewhere around 17 to 25-year-old. Between that is the most frequently, but we had seen patient coming after that, maybe elderly patient also we had seen coming with testicular torsion. So one thing you said is testicular torsion. Agreed. The next thing.
then epididymoarthritis can be kept as a differential.
Epididymoarthritis is the second most common reason for the inflammation of the orca and epididymitis. Maybe it can be simple epididymitis or it can be associated by epididymoarthritis. Next.
Foreigners gangrene should be ruled out.
Foreigners gangrene, pain. I'm just saying foreigners gangrene, definitely there will be skin involvement and all those things. Okay, agreed. Then next
Any
one.
inguinal hernia.
Inguinal hernia. Okay, now it can go into the scrotum and they can come with it's telling that they have a scrotal pain. Next thing. Hydrocele, an infected hydrocele and hydrocele, varicocele. Varicocele, the most common thing what can happen, no? Varicocele, they will have this tortuous vein. Maybe after a small activity or something, they can have small thrombosis formation inside this vein. So they can come with significant, just like thrombophlebitis. Imagine a thrombophlebitis happening in the hand. Similarly, they can come with varicocele patients. So varicocele patient background, they are coming with pain. One thing that we need to look in for is this thrombus formation. So that is varicocele. Then hydrocele, varicocele, infected hydrocele, infected varicocele. Then calculi, ureter calculi, most common thing. The classical history, they will be having referred pain to the testis. So ureter calculi. Then the last might be a malignancy. Rarely any testicular malignancy, the patient can come with this thing. Then scrotal pain. What are the other structures in the scrotum? Most common thing, folliculitis, scrotal folliculitis, that very paniculatus, folliculitis, all those things is very common. Unless and until you are examining that, you will not, the patient will not be aware of this thing. He will just come about because of a lot of hair follicles are there, they can have a folliculitis also. So that is again diabetes, uncontrolled diabetes. So that can lead on to, just like our cellulitis, it can start on to an infection and proceed. So these things are the most common differential diagnosis. So now we will come to the epididymoarthritis and to torsion testis. We have already said, and the position of the testis and all those things, we have already discussed that. Now, in specific regarding epididymoarthritis, so we have a patient now very clear, etiology wise I am very clear in my mind why he has developed an epididymoarthritis. Remove him, and we have got another patient, 30-year-old, who has come to the ED without any history of this obstructive uropathy reflexes, and he is coming to the ED with a testicular pain, and you are suspecting an epididymoarthritis. So how will you proceed that for that patient? What will be the possible etiology for that?
Recurrent UTI.
Why a 30-year-old male should develop a recurrent UTI?
Sexual.
Again, sexual history is the one important history where it is relevant in ED to ask, is this in this group of patient where you think you are not finding any reasons why he is developing a sexually transmitted diseases, and you need to keep in your mind, and that history might be helpful in that scenario to ask for. Maybe this patient, I am very clear, he is having possibly a gram-negative infection. So recurrent UTI, he has self-intermittent catheterization. So gram-negative is what there in my mind. But whenever a patient with a high-risk sexual behavior and is coming to you to the ED, so that thing you have to consider epididymoarthritis. Then next thing, what will you keep in your mind? We have already said this. Patient coming from an endemic area for filaria. So filariasis. So that is the next thing. Filariasis can also present with epididymoarthritis. So you have to start the treatment with DEC and all other drugs. So these are the important differential diagnoses that you need to keep in your mind. And why a patient of a young boy should develop epididymoarthritis? A 14-year-old boy should develop an epididymoarthritis. When somebody, a young 14-year-old boy or a 10-year-old boy has come to the ED and you are suspecting epididymoarthritis and it is proven epididymoarthritis, so what is the next thing that you will think in your mind? You said, what is the thing that you can happen in children? A male, what you can have? No, epididymoarthritis, reason for epididymoarthritis. Reflux disease. vesico-ureteric reflux disease. So that is the reason why they are having. Otherwise, they should not be developing these things. So whenever you are having this reflux disease, you need to evaluate those group of patients. So this is what, whenever you are getting an epidermolysis, depending upon their risk factor, age, and their sexual history, you need to differentiate whether I am dealing with an E. coli, whether what is the most common thing other than epidermolysis, orchitis for that reason, mumps orchitis, very common. We had a patient last year post COVID, and he had an classical mumps and following orchitis, mumps orchitis. Any drugs can cause orchitis. Any drugs? Any drugs? Okay, that I'll give you as a homework. I will not say here. One drug that we commonly use in the ED can very rarely it can produce orchitis. So orchitis. Next thing, what you need to remember, you can have torsion testis. We can have. What else can get torsioned?
Epididymis.
Epididymis itself can get torsion. So it will be an not a testicular torsion, and epidermal torsion also can happen. So they will come with the pain. So a patient coming to the ED with the testicular pain, what is the most important thing that you need to do? A proper physical examination. So a proper physical examination is what is going to help you to differentiate between an testicular torsion and epidermolysis. If it's a testicular torsion, it's totally an emergency, and that patient should be immediately sorted off with. Maybe you can try for a manual detorsion techniques if you don't have a surgical facility, or otherwise the surgeon should be immediately alerted for an early fixation. If you think that as per your evaluation, it is more likely to be a testicular torsion. So don't do half-hearted examination. Do a proper testicular examination, and you differentiate between epidermolysis versus your testicular torsion. If it is epidermolysis, okay, we have time. Then, as you said, you can go the blood lab investigation and a urine routine examination. Then you can get an ultrasound Doppler, and you can see why he is developing these things. And you need to start the treatment. So, how will you start treatment now?
We initially classify whether there is STI risk or not. If in case of STI risk, then we go ask the history whether there is some anal intercourse or not. If there is no history, then we go with ceftriaxone, 500 mg IM stat dose will be given, and then start the patient on doxycycline 100 mg BD for 7 days.
Okay, so that is one regimen. When you have a higher risk sexually transmitted infection risk factor, you will start with ceftriaxone. We can give 1 gram stat or 500 mg stat, and you can ask them on doxycycline and put them on. Then,
if it is low risk, then we go with ceftriaxone again, 500 mg stat dose with the fluoroquinolones we can give. We can go for levofloxacin 500 mg for 7 days.
okay,
If there is no risk of any STS, then simply fluoroquinolones can be given.
can also be given. So that is how we need to differentiate between this group of patient, and at the end of the day, that is for your epidermolysis. But when they are coming from high endemic area, I add DEC also, diethyl carbamazepine also, and usually epidermolysis you can discharge them from the ED unless and until you have taken an ultrasound and Doppler, you have proven that this is epidermolysis, you are documenting this. You can discharge the patient with these regimens, and the only thing that warrants them to be admitted may be an associated urinary tract infection. So an epidermolysis like this for patient, maybe an urinary tract infection also might be there, which is taking him into a sepsis. Epidermolysis, usually it is a self-limiting disease, which is a reasonable. Only thing, pain will be there. Pain management need, for that reason you might need to admit the case. But otherwise, usually they can be managed maybe 2 to 3 hours of ED observation. They will be all right, unless and until there is another indication for admission. Routinely, we need not admit these sort of cases. And you have taken an ultrasound, and you are pretty sure that if there is no torsion that is there, and you have documented everything, any of this regimen, depending upon the risk factor, you can discharge them. But patient might come back with the pain. So you need to give good analgesics. So that is the most important thing that you need to keep in your mind. Anything else that you want to add on? So what was done for this patient?
This patient was USG was done.
Where you will classify this patient, high risk for STI, low risk for STI, or very low risk for
very low risk.
Very low risk. Okay.
So this patient was given levoflox 500 mg OD for 7 to 10 days, and then NSAIDs was started for him for the pain relief, and then scrotal elevation, if possible, was recommended for the patient.
Okay.
And for the edema to resolve, chimeral port also was started.
Was given. Okay. So in a nutshell, what we have discussed is the your testicular emergencies. Most commonly, 2 emergencies that what we deal. Mostly it is a torsion or an epidermolysis Very rarely you can have a testicular hematoma following a trauma, maybe a scrotal hematoma following a trauma. That is a separate entity related to trauma. But here what we said regarding is epiderma orchitis, and what are the common differential diagnoses that you need to keep in your mind when you are seeing a patient with testicular pain. So most commonly that I have said, maybe very rarely an undescended testis. So that is another this thing. Depending upon the age group, you need to think whether you are able to, when you are examining, you are not able to find an testis and descended testis, which can have a radiation pain to the scrotum also. So that is the possibilities that you need to consider. Anything else that you want to add on? Okay, fine. Thank you. Yeah.